Sha Wu Hao. Every time I come to China, I try to learn at least one. So 100 years from now, I'll be almost fluent in Mandarin. So thank you again, Hongbo and Jim Liu, for the opportunity of being here. I'm going to share with you in the next 15 minutes a little bit of work that we did a couple of years ago with Medina Coils. And for disclosure, Medina is not approved in the United States, has CE mark, but has no FDA approval. Again, this is again our house in Jacksonville, 2 hours north of Mickey Mouse, Orlando in Florida. Those are my disclosures. There's no question that we need new technology in our field. Coils have been revolutionary when they came to aneurysm treatment in the 90s, and it remains in 2017 our daily workhorse. But we know we have problems when we deal with the coiling of aneurysm. I call the 4 R's that are residual, recurrence, rebleeding, and retreatment. We're dealing with aneurysms. We know this is our weakest link when we're dealing with coiling. There is an avalanche, an eruption of endoluminal tools, and we see many of those. We talked this morning, and there are many more coming our direction. You can see this list here on the left side. And when you look at endosaccular options with the web that is going to be presented here, RTs and others coming for endosaccular. And Medina is on that, is an endosaccular tool for treatment of intracranial aneurysms. I think it remains an unmet need, treatment of rupture intracranial aneurysm. When you're dealing with a subarachnoid hemorrhage, that is still about 50% of the work that we do every day in our center. We're dealing with a subarachnoid hemorrhage. Stenting technology is not a good option for these patients, and we try as much as we can to avoid using a stent in rupture intracranial aneurysms. So the idea is to put your horse on steroids. So Medina is a Pegasus, is a coil with wings, as you see here, and you see here well demonstrated in a picture, close-up picture of the Medina coil, where you have these petals or wings on the coil. Starts with a leading platinum wire, and you have these wings opening with a radiopaque mesh that goes through a 21 microcatheter, enhancing feeling and getting a more uniform coverage of the neck, as demonstrated here. So the idea, if you think about what will happen to a coiled aneurysm, is that you have all these irregular cylinders, that is your coil, or if you use delta coil, that shapes like a pyramid in a cut, or a triangle. With the mesh of the Medina, you're going to have a much more uniform coverage. And here you see on this animal study that you have that mesh of that pedal sitting right at the neck of the aneurysm, creating a much more uniform surface for the healing, endothelial-like, nice, smooth surface to grow. And we know that with our stents and our flow diverters. So if you can get a more stable surface for the endothelial cells, you're going to create growth of that. So that's the thought process behind the Medina coil that was by a company named like this, and now was acquired more recently, about 2 years ago, by Medtronic. It is delivered through a 21 microcatheter, and there's work being done to get that to go through a 17 microcatheter. Those are the microcatheters that we use with Medina, most of the cases with a Prowler Select Plus, in a couple of cases with Vasco 21 by Bolt. You have two types of coils. You have framers and you have fillers that go single length, 6x8, 7x9, and so forth and so on. And the fillers that are smaller and softer on this size is available. This is a preliminary result of our experience of cases done under compassionate use of devices in Brazil, in conjunction with Dr. Orlando Maia at Teresópolis Hospital. So we treat these 12 aneurysms, and I'll go back to that in a second. None of these patients on dual antiplatelet regimen. We had no major clinical adverse event on the first 30 days, and this goes up to 1 year with no adverse events. We had one case where we had a protrusion of a winglet of the pedal of the Medina into the parent vessel with a thrombus formation on that pedal, requiring a enterprise stent placement for salvage of that and avoidance of a complication. All these cases done under local anesthesia. This is the work that we published in 2016 at JNIS, and we got lucky that we got the cover of JNIS that month. And you're going to see results like this. This was the very first case that we treat with Medina device. This is a 12 millimeter snowman shape, and we learned that today, if we would treat this with Medina, we would pack the neck, pack the dome with a coil or a smaller Medina and use the Medina coil to frame. You're going to see here that we did something different. We started with an 8 millimeter framer at the top, and we create ourselves a tough problem is that this residual neck here, not very easy to frame with the Medina coil. But you see here the first coil in place, and this is the X-ray view. You can see the winglet. It's not as easy as to see the body wire of the Medina coil, but you can see the winglet or the pedal showing on that. And this is after placement of a second Medina, and now we went and put a 5 millimeter filler. So what I meant to show you in terms of strategy of using this tool, if you had to use this tool again to treat these aneurysms, I would start with a smaller one at the dome and leave more space here for my framer, because then I can have a nice placement of that pedal of the Medina towards the neck. So there's a small learning curve here with this type of device. So here you have a second 5 millimeter device in place, and now you're getting a better neck coverage, but the filler does not cover as well as the framer. And now Medina is compatible with any coils. In this case, we use a microplex 4x10 to complete and finish the neck of the aneurysm. So we use 4 Medina coils and our devices, and we use a 1 microplex with this final result. And then you see here the 1 month follow-up. We had a small neck remnant that remained stable at 6 months, as you see here. Unfortunately, this video is not playing here, but that was just to show you the appearance of that on an angiographic run. In other cases like this one, this patient has a carotid terminus aneurysm, and on this case end up being a one-and-done case. Medina is not designed to be a Webb/Luna/Artis, one device and you're done. You gotta treat Medina just like you do with the coils. You have to pack the aneurysm till you cannot pack anymore if you want to obtain a stable occlusion. And on this case, we put a 6 millimeter framer, and we could not get anything else inside the device, inside the aneurysm. So we stopped here because we could not put any more coils or Medina device inside. And here you see the penetration of contrast into the sac and the stasis that is very important when you're dealing with a endosaccular. You're trying to disrupt flow there. You need to see this stasis for the device to work. If you have a clear wash-in, wash-out of contrast, you know you have not changed enough the dynamics inside the aneurysm, and this is not going to close. So when you look at these aneurysms before and after, immediately you have that. When you look at the 6-month follow-up image, you have this nice stable occlusion of the carotid terminus with a single device in place. Other aneurysms like this, wide neck MCA aneurysm, not very easy to treat without a stent. This is a 7 millimeter Medina device in place, and we end up continuing this with 2 5 millimeter Medina fillers. You see this is nice straight line here at the neck of the aneurysm, and here you still see penetration of contrast, but you see the stasis, the retention of contrast into that. Medina coil is a bit or is less radiopaque than your regular platinum coil, so it's normal, just like you see with a Webb, to see this penetration of contrast. But if you see stasis, you know you're going to end up with a stable result. And this is the case with this one here. Unfortunately, not playing again. I want to show you the appearance of that to you guys. But here you see the final result on a 3D. And this is the follow-up angiograph showing a nice, stable, and you do have a small neck remnant, but as you can imagine, this was a rupture aneurysm. I'm happy with this result, and now if I have to deal with this, I can deal with this in a delayed fashion without using a stent. I don't think I would be able to treat this with the primary coiling, maybe with balloon-assisted coiling or clipping. For whatever reason, my clock stopped working here, guys, so I don't know how much time we have left. I don't know, it's not running for you guys either there. So please let me know when we are, the clock has stopped working. This is a previously clipped aneurysm, broad-based, all-neck aneurysm. They were able to treat, again, with a single device in place. And this is an 84-year-old guy with a 30-day post-subarachnoid hemorrhage. Hunt has one with this wide neck, 14-millimeter anterior communicating artery aneurysm that we treated with the Medina device. And you see here, we're putting the largest Medina framer, and you can see here nicely the pedals of the device, just to illustrate that for you guys. And you see the pedals again here on this unsubtracted image. And here, you see just from placement of the device inside, you have retention of the contrast. And this is very rapidly thrombosed. And you just keep filling over and over and over with this material till you get to this point where you have a nice straight line at the neck, and you're still going to see some penetration of contrast, but with the stasis of contrast into the mass. You see here both ACAs filling from the right side injection, and you see here a nice A1 on the contralateral injection, and here you see the 6-month follow-up. In a wide neck, 14, 15 millimeter ACOM aneurysm with no stenting, you got a super nice, stable result with no recanalization. So the appearance of the coil mass is different than what you get with your coils, but it gives you a nice, stable result. This is the results of the Stuttgart series by Professor Henkes, just published about a year after ours, where they did 16 cases with 10 cases using adjunct devices. They had a follow-up in 11 cases, 10 with stable total occlusion in 4, stable remnant in 6, and 1 case of recurrence. This is as far as we have in terms of results. Nader Surur from Paris has probably now the largest series with about 20 cases done, and the device is undergoing new iterations, trying to bring the device to a smaller frame to bring the device through a 17 microcatheter. In conclusion, the Medina system is a next generation device that brings to us all the familiarity that we have of treatment of aneurysms with coils. As I told you, this is a coil with wings, with a potential improved circumferential coverage of the neck and potential better stability and longer-term results. No need for dual antiplatelet. This is an endosaccular device. It's all inside the aneurysm. There's nothing left on the parent vessel, so very nice alternative for rupture wide neck aneurysms. Naturally, you cannot make any firm statement. We just talked about earlier today about we should be data-driven. You cannot make any fancy claims on 20 case series from here or there. We need a large-scale, prospective, independently adjudicated study showing that the device is an option for treatment of wide neck aneurysms, especially for the rupture ones. And I'll stop here. CSA, one more time, I appreciate the opportunity of being here at Ocean with you guys. Thank you.